presentation. So, good evening, everyone, and thank you so much for joining us for this roundtable. Now, you will notice remarkably that we don't have a roundtable in front of us, which is going to make this extremely difficult to run, so bear with us as we try to run a roundtable as a symposium session, both with attendance online and in person. This roundtable was born years ago, and it was born because we needed to have a discussion, and it was born out of a meeting that Katrin and her team at WHO organized for all of us to attend. At that time, ADI was still the organization that published the numbers globally for prevalence and incidence. We started doing that in 2010, and we did another report in 2015. But our intention was always for those numbers to be acknowledged and recognized by the WHO. We wanted dementia to be owned by WHO, and this is what was behind the Global Action Plan for Dementia. So adopting the number was the last big thing that really mattered to us. Since then, there have been a lot of discussion, and Katrin will tell you more about them. And critically, we've been trying to work as a group to understand the need for these numbers, where they should sit, who should be doing them. And this discussion has been extremely productive, and we've all been working together. But who are we? So there's a lot of us, and half of us are on one hand of the round table, the other half is virtually online today. So there's a lot of people that will be participating. Now, I'm hoping that we'll be able to take some questions. We may not be able because there's a lot of us. Let me introduce you to my fellow panelists. In person on the stage, we have Katrin Seeher, who is at the WHO, Adelina Comas-Herrera of the LSE, Sube Banerjee of the University of Plymouth is there, sorry. Nicolas Farina, Brighton and Sussex Medical School is here. Anders Wimo is there from Karolinska Institutet, and Martin Knapp is at the end. Online, and speaking today, we have Emma Nichols at the University of Washington, who is part of the Institute of Health Metrics and Evaluation. Also with us online and about to speak, or participating in the roundtable, I should say, Cleusa Ferri of the Universidade Federale de São Paulo, Brazil, and Rodrigo Cataldi, I can see, of the WHO. I can see Theo, also of IHME, University of Washington. We should have Maëlenn Guerchet. We have Maëlenn. Ciao, Maëlenn, who miraculously has managed to connect. She was having a great problem where she was, of the French National Research Institute for Sustainable Development. And we should have Martin Prince, who is currently in Ethiopia. Ciao, Martin. Trying to connect, and he has connected. So we got everybody. So with that in mind, this is the most difficult panel I have ever done. So it's really tricky. Let's see what's going to happen. I will hand the floor to the first speaker of today, who is Katrin Seeher. Katrin.
Thank you. And I think, unless, do I go there or?
You probably go there. No, you go here.
We haven't planned this properly.
No, we haven't.
Okay. Thank you, Paola and ADI, for bringing us all back here in this round to discuss this incredibly difficult but important topic. As you've heard from Paola, we do need to have a good understanding of the global number of people living with dementia, just so that we can plan services, not just current service needs, but also prepare for future generations. So it's incredibly important for us to know how many people live with dementia at the moment, how many people are dying with or from dementia. We also need to know how many years of life we're living with dementia, and in what stages of the disease, because that would also have implications for service planning. And then, last but not least, and you heard Anders in the previous plenary talk about that also, we do need to know how much we as society spend on providing care for people with dementia, and that includes the tremendous service to society that informal carers shoulder. And again, Anders has spoken to this in the previous panel or plenary. In September last year, WHO released a global status report on the public health response to dementia as our kind of like midterm review of where we are for reaching the global targets of the Global Dementia Action Plan. And some of these figures were included there as global and regional estimates. The reason we're not reported on country-level data in that report is that there are certain issues that we're going to talk about today in this panel when it comes to the certainty that we have for national level data. And I'll come to it in a second. But just to remind us all, the Global Status Report, for example, pointed out to the fact that dementia is the 7th leading cause of death. You would have heard Tarun yesterday in the first plenary remind us that the disability due to dementia has more than doubled, or almost doubled, in the last 20 years. So I think the spotlight is on, and having these numbers is a good reminder and is also a good justification whenever we talk to countries and remind them on the urgency to act. I'm not going to talk about dementia-specific prevalence figures because I believe we have Emma on the call virtually who will talk about specifically GBD data. Just for everyone to know, GBD is the most comprehensive undertaking globally to assess disease burden, and at WHO we do rely and use their estimates for many of our models. But our models and our data are only as good as the input information that we actually have. And so I want to spend the next 1-2 minutes, I'll try to be quick, yes, on what are the issues that we have with the input data. First and foremost, we do have many countries where there is basically no population-based information available. So that means we do need to make imputations, and they do come with uncertainties. In the health systems, often dementia, as you all know, is not recognized or detected properly. So we're underestimating the number of people living with dementia. And these two in combination really hamper our ability to monitor the global target for Action Area 4, which is the diagnostic rate of dementia. So we do want to remind everyone about the importance of creating better input data. There are other limitations that I don't want to go into, but just to, for all of us to remember and appreciate that we do need to work on our input data. So I think with that, I'll hand the microphone back to Paola and see.
You can keep it for the next speaker, who is going to be Emma. Actually, Emma is going to speak next. But I wanted to thank Katrin. It was an important introduction. I would also like to remind all of you, in Plan to Impact, which is the latest report we've published, there is a very, very good summary of the story so far that has led us to this roundtable. We are running it as a roundtable. So we have had this conversation. We are letting you in the conversation now. But the conversation has been progressive, so we are not telling you the whole history of what's happened here, although some of you will be wondering, but the whole history is actually summarized very neatly in Plan to Impact. Now, without further ado, and I notice we've lost Martin, the probably is trying to connect again, and I send you the apologies of Emiliano Albanese, who has just texted me to say that he is in bed and not feeling very well, so he's apologizing not to join us. Emma, I hand over the floor to you, please, on your update.
Great, thank you
Emma,
so much.
Can you hear me? Yeah.
Yes, I can. I'm waiting for slides. Are those going to show? Yes, okay. So I'm going to just talk briefly and follow up with what Katrin said about in terms of sharing our dementia prevalence estimates and some estimates of forecasting as well. The next slide. And so I do want to sort of re-emphasize this point that was made earlier about input data sparsity, because while we are able to make estimates for every country, drawing on places where we have data to inform places where we don't, the quality of those estimates really hinges on the quality of the underlying input data. And this really is the best way to improve these estimates in the future, is to start to fill in this map. So places that show up with white are places we don't currently have data, and you can see large gaps in places like Eastern Europe, Sub-Saharan Africa, and parts of Latin America as well. So next slide. And I do want to highlight that even with the data that we have, there is some variability in the methods used to measure dementia, which can also lead to challenges. There is consistency in the definitions used for dementia, but large variation in the specific methods for ascertainment. So we found that of 287 sources we cataloged, there were 279 different diagnostic procedures used. And we tried to adjust for some of the variability that this might introduce, but there is always the possibility that some of the observed differences between countries that we assess may be artifacts of differences in methodology. Next slide. But even with all of these issues, and despite limitations, we do pool all available data to produce estimates of global burden with appropriate uncertainty to correctly characterize how certain we are given some of the limitations in underlying data. So this map shows age-standardized prevalence for men in 2019, and policymakers and countries can use these estimates to inform public health planning efforts and advocacy efforts in the future. Next slide. So one area that we added in the past year was to add forecasts of dementia prevalence. So you can see our estimates through 2019 and forecasts out to 2050. And you can see while age-standardized prevalence is expected to remain fairly stable, we anticipate large increases in the all-age number of individuals with dementia due to trends in population aging and growth. Next slide. But it is important to note that you can look at the global trend, which is very informative, but there is variability in the expected magnitude of these increases. So this map shows the percent increase between 2019 and 2050 in the number of cases for both sexes. And you can see the largest anticipated increases in the number of cases is expected in Sub-Saharan Africa and North Africa and the Middle East. Next slide. And then finally, in this analysis, we were able to decompose the drivers of these anticipated increases, and we saw variability by region. So I'll just walk you through the main points. And the dark blue bars on the left, you can see we actually expect some decreases in the overall prevalence number of people with dementia that we can attribute to increases in the prevalence of higher levels of education. But this is roughly counterbalanced by expected increases in prevalence due to changes in the prevalence of risk factors such as smoking, high blood sugar, and obesity. So those roughly counterbalance, but the majority of the increases that we anticipate are due to demographic shifts. So population aging and population growth, although the relative importance of these two factors does differ quite substantially between regions. Next slide. And so with that, given sort of the limits on time, I'll wrap up with just some places that we want to move this work forward in the future. We want to incorporate additional risk factors into the global burden of disease, which will allow us to incorporate these into a forecast as well and allow the prevalence of risks in the future to influence the future trajectory of dementia. And then will also allow us the ability to estimate the impact of various interventions and scenarios. So to understand how, when conditions change in the future, how that can affect dementia prevalence. So scenarios either related to demographic trends, but also how might policies that address modifiable risk factors impact dementia prevalence as well. So with that, I'll hand it over to the next speaker.
Thank you so much, Emma. Interesting to see also your future direction. I'm delighted that Anders, who is the next speaker, has come back on the panel as if he never went away. So, Anders, over to you.
Well, thank you. Here you see the basic estimates of the global cost is about $1.3 trillion in 2019, and how it's distributed amongst different payers. Of course, the prevalence issue is crucial for the cost estimates. So I have, in a sensitivity analysis, I have tested also to apply not the UN population statistics, but instead I used the IHME population statistics, and the total figure then is just slightly higher. It's $1.34 trillion. I also applied the ADI or King's College prevalence data combined with UN population data as well. Then the figure is a bit lower, $1.2 trillion. So, and in the estimates from IHME, it's about 57 million people with dementia instead of 55 million with dementia in the WHO report. And if you use the ADI, King's College data, it's about 57 million as well. So I think this is not actually a major problem any longer. We have a slight variation in the prevalence estimates, and also that results in a slight variation in the cost estimates. It impacts the distribution in different countries or world regions in terms of World Bank classification issues in the world. So it has an impact on that in a way. But for the global estimates, the impact is rather small, actually. And then the next slide, please. Yeah. But what I want to highlight more is perhaps the impact of unpaid informal care. This is a very complicated issue because the way of quantification and also cost informal care, it's a very complicated issue. And actually, if you test different inputs in all ways, the range in cost of informal care vary with a factor of almost 10. So transparency is extremely important when you present cost data in informal care, and we need a 3-day conference to discuss these issues, I think, in a way. But nevertheless, the other one is the contribution of female women, particularly in low-income countries, in low-middle-income countries, because it's 70% in average, but it's almost 80% in low-income countries, and in high-income countries, the carer is mostly a spouse. But in low-income countries, it's mainly a daughter-in-law. So that has a great impact on the ability for young women to enter both the education and working market for women in this country. So we need to discuss the trade-offs. On the one hand, what is good for the people with dementia on one hand, but on the other hand, what's good for the young women who are working as informal carers now in low and middle-income countries. Yeah, thank you.
Thank you very much, Anders. We've asked everybody to do very short interventions because obviously we want to have an opportunity to speak, and also for you guys perhaps to do us give us questions from home. Now I hand over the floor to Sube Banerjee, who of course has been incredibly involved in the STRIDE project and has just finished a couple of really interesting studies that add the new information and material to what we already know. Sube, the floor is yours.
Thank you very much. Great pleasure to be here, and thank you very much for having delayed the start of this session until after the cricket match finished on the pitch. Sorry, and you'll want to know this particularly of people who I think are joining from Brazil and other places. Basically, Surrey schoolboys beat the Afro-Caribbean group, which is a bit unfortunate but that's what happened. So there we go. There was hope at the end, but I'm afraid they lost. So I've been asked to make some short points, and I'd like to make just 3 points, really. The first is, following on from the absolutely fantastic global data that we've been hearing here, and it's absolutely vital that we have the global data. It's vital that we make the international priorities for dementia. But local data is absolutely vital. You know, it is not, we ask the question, I think, why do we want the data? And the reason we want data is because things are bad for people with dementia and their families wherever you go, and we want to change things. We want to change things for the better. And in order to change things for the better, what you need is the development of policy and priority, and you need the development and delivery of services that enable people to improve the quality of care for people with dementia and their carers, and therefore improve the quality of life of those individuals. So that's what it's for. It's about improving stuff. And global data gets you so far. It's great. But it's local data that really cuts through. You need politicians and policymakers, who are the people we're talking to here. It is not helpful to say what happened 5 years ago in a country not that far from here. You need to be able to talk about what happens in your country. And what we've been doing in Stride is trying to generate something quick and simple that enables local data to be generated. And if we're thinking about local quantitative data, then it's not just about the numbers. The numbers are the first step and they're really important. But we absolutely need to know what it costs. We absolutely need to have the cost data as well, because if you're looking for the levers that make politicians do stuff, that makes policymakers prioritize things, it's cost as well as numbers. And if you're looking at that as well, you also need to know about the impacts on people with dementia, the impacts on families with dementia, the impacts on society more generally. And again, the Stride programme provides a package that is modular, that enables you to add those things in. So there's nothing more important than those data. Now, people often start saying, well, you know, these local studies, they have all sorts of errors involved in whatever. And I would say, as part of this, that the worst enemy to making good policy is the over-rigour of epidemiologists like myself, who get ludicrously caught up in the third decimal point of an estimate and don't see the big picture. The important thing is that it's about 10%, not about 1%. But actually local data that says it's about 10% in KwaZulu-Natal or wherever, so much more important in South Africa than saying that it's in, you know, even Kenya or Indonesia or whatever. So local is powerful. Second thing I want to say is that data is not just quantitative. You've got to change minds. You've got to make the case. And if we're changing minds and making the case, the data that we need are, yes, the quantitative data, and yes, the quantitative data in our countries, but we also need testimony. We need qualitative data. We need to absolutely engage and enable people with dementia and their families to tell their stories, to get those stories into the culture of a country, to generate that narrative that calls for change, that makes for the priority of dementia. And so it's absolutely vital that we remember that there are qualitative pieces of work that we can do that will generate data that will make our quantitative data sing and make them break through. And again, Stride has a set of things that enables that. And the third and last thing I wanted to say is that we've done great things in improving the priority of dementia. We've heard some of the fantastic things World Health Organization's done over the last decade in terms of building the priority of dementia, but there's just absolutely no room for complacency in terms of where dementia is, in terms of priority. We do not have the same priority, the same visibility, the same understanding in countries across the world than we did before the pandemic. Health systems and services throughout the world have been immensely challenged, and in the stress test that has been the pandemic, there are some things that have gone way down in terms of priority. I think that dementia has, people with dementia lost the war of COVID in terms of the immense increased mortality of people with dementia, the incredible stresses on family carers of people with dementia wherever you go in the world. We lost the war. We're in danger of losing the peace. So there's never been a more important time for us to have great quality local quantitative data, to have great quality local stories, to have a situational analysis of a country that enables the case for better care to be provided in each country. It's because we've gone back 10 years in the last 2 years. We need to regain that and go forward, because it wasn't perfect before that. So a fantastic agenda for data making a difference. Thank you.
Thank you very much, Sube. So to summarize our first 4 speakers, you've heard quite a lot of arguments, and now I'm going to bring in the people that are online and on the panel with us to comment. But a couple of points. So at ADI, obviously, we talk to governments all the time. As Sube was just saying, the weapon of numbers that are relevant to them is very important. However, we are now a long way down the road. Shouldn't governments start taking this data for themselves, start doing these studies for themselves? But if they do, can we trust them? I mean, we're civil society. We're here to question that data, to ensure that that data really is the data that they say there is. And the WHO is the Global Dementia Observatory, which is great, but government put data into that, and sometimes we know that data is not exactly correct. There are other questions. So obviously we're super happy that the WHO now has embarked and taken on the data for dementia. That's been really, really important for us. But once again, for us it's been fabulous that the data, as Anders pointed out, has really converged. So what was published by IHME and the WHO really brings us back to the data that Martin, who is with us, is not on video but he can listen, found out for us in 2015. So we are going in the right direction, we know that, but what do we do next? What is that we should really be focusing on? We have the legacy of 1066, for example. Should we encourage more people to do 1066 at local level? We have the new legacy that Stride is leaving us. Should we encourage people to do studies in that direction? In general, we need more data. I think the panel has agreed. At what level we need it? Government level, at the national level, should it be university that do it, researchers? So let's open up the debate. The first person I would like to comment on this is Martin Prince, if Martin is on, can hear us on the line and has a microphone on. Martin.
Can you hear me?
Yes, very loud and clear.
Okay, I've switched my video on, but I haven't reappeared, so I'm not sure why that is.
The ghost of Martin is echoing in a beautiful room, Martin. I'll send you the picture.
So I did another conference call from the street in Ethiopia yesterday, where I seem to get the best Wi-Fi signal, but let's hope this works. So very briefly, thanks very much, everyone. It's really nice to see this work continuing to thrive, and I think in many ways with great continuity from the work of the 1066 Dementia Research Group, and also the work that we did with you, Paola, and predecessors at ADI through the observatory, working with Cleusa in the first instance and Maëlenn on the work to generate the global figures in conjunction with ADI. And it's extraordinary that these estimates from different sources now seem to be converging roughly around the same global figure that I think adds to the level of certainty and the conviction that comes with these data. I think one of the things that we were able to do back in 2007 was come up with one number that people were not contesting, that everyone could join around. My thought, there's been some discussion about the country-specific numbers. For the numbers that we did from King's with ADI, as you know, Paolo, we never actually published country-specific numbers, though we generated them on the way to coming up with our regional estimates. And the reason why we didn't was that we were somewhat uncomfortable where no data existed in the country to be applying a bit of guesswork, essentially based on the prevalence figures that were coming up from elsewhere in the region. But I think it probably is fair to say that we weren't actually getting the outliers in our country-specific estimates that are appearing from some of the IHME models at the moment. And Emma, you alluded to that, and I wonder whether really, perhaps you're doing this already, some closer inspection of those models and trying to understand the factors that are accounting for some of these peculiar looking outliers from individual countries, and to see whether constraints can perhaps be built into those models in order to deal with those. Because I think while we as knowing something about modeling can kind of understand and accept that these things can occur, when we're talking about the confidence that policymakers, associations and others in individual countries have around data, they may interpret these things concretely if we're not careful. I completely agree with Sube. and with others about the need not just to focus on figures, but to get a sense on care, on the impact of care, on the quality of life of people with dementia, and on the economic costs. These are the set of figures that we were generating from 1066 Dementia Research Group. It's really, really important. The final point that I'd make is that I'm a firm believer now that globally we need to transition towards governments taking responsibility for generating estimates of all of these things through periodic surveys. But I think in a transitional state, we need to remember that even in many sub-Saharan African countries at the moment, while there may not be periodic nationally representative studies of health and aging that are being funded and commissioned by governments, there are independent research organizations that have well-funded studies of health and aging that gather comprehensive data, including in many of these studies, as I've been finding out with a contact recently in Uganda, including cognitive data on all the people. And it would be a very short step indeed, and a very cost-effective step to actually use those either through a second phase survey or through including just some additional questions in further ways of the survey, to use those to generate prevalence estimates. I think there is a research capacity issue otherwise, and we need to be cautious about trying to run before we can walk. And not all surveys are necessarily helpful. I think if they're too small, if the quality of the work is not adequate enough, these may not help in any significant way. But these well-funded, well-run studies with expert investigators on health and aging, that for me would be the area to go, and to actually work with those investigators to develop methods to take them from assessments of cognition and functioning into meaningful estimates of probable dementia diagnosis. So thanks. So those are most of the things that have occurred to me in this very interesting panel. Thank you.
Martin, thank you so much. We have heard your disembodied voice loud and clear in this room.
Okay.
And it's very nice that your last remark echoed exactly what Katrin and I were talking about earlier around, for example, this big problem we are having with the diagnostics figures. Now, it's been a very important intervention. I'm sure many of you will watch this roundtable again because it's very dense of content in the few words that we've allowed people to say, so apologies. I would like now to call into the discussion a person that is collecting that data in a country where there was nothing until a decade ago. Cleusa, can I please ask you to come into this discussion and comment? So Cleusa Ferri from Brazil.
Oh, hi. I just would like to maybe strengthen some of the things that have already been said. In Brazil, we are very lucky to have a national data supported by the Ministry of Health. So like Martin said, we do have a health and aging study with more than 90,000 people, representative of the whole country. And it's a huge country, as you know. But I think it is an expensive study. So we do need to get the governments, as Martin was saying, to understand that that is essential if you want to have data that's reliable, that's representative, and that not that we do just one study like most of the studies, for example, in Latin America, on incidence, they are just done with one follow-up and they die. So we don't have any data that follow up people over time, that you can understand that if you're making any change, in the risk factors, in the profile of the risk factors for dementia in the country, in Brazil, I think is improving in that matter. We can't see the changes in the prevalences, over time. So that I think would be important, not just to have these studies, studies that are good quality and that, if possible, represent the population of the country, and that can be monitored over time, not just a prevalence study that dies or incidence studies that have only one-time follow-up. I think that's what I'd like to reinforce. And I also just would like to say about what Emma had said on the differences of prevalence that that can be due to methodological differences in these studies. I think that is very important. We need to understand how much of these differences are due to methodological issues and how much are real differences, because we may have very important differences, and that would be very important for insights on risk factors and other issues related to dementia locally. I think for me is that open to talk more if needed.
Thank you very much, Cleusa, and I hope your ankle is healing fine. Cleusa was at the pack already ready to come here, and then she slipped and broke her ankle. So I hope you're getting better.
Got my leg up here.
Oh, and following us online. Thank you so much. I would like now to call next on Martin Knapp to comment on what he's heard so far.
Okay, this is Martin Knapp, who wasn't expecting to speak today, so
no.
Hence been writing.
You're always
being
being called into, you're in the panel, you know what's going to happen.
I mean, just two or three quick things. One is to say, I mean, I think, firstly, the global burden disease industry, I would say, has been enormously helpful in contributing data. And the slides that Emma showed, I have shown myself in teaching and lots of other presentations. It's a really good place to give us that basis. So that's really important. But what's missing in those measures, and it's hinted at by Anders, what's missing is the health impacts on carers and caregivers, which can be directly associated, I would say, with dementia. It's not a criticism of GBD, but I think we have to remember that dementia care is very often dyadic care or dyadic relationships that's there. So I think then, I mean, Sube's mentioned STRIDE, and Adelina and I have been leading STRIDE for the last 4.5 years, and there are quite a few STRIDE people here. We are trying to get behind these sort of figures to see what's going on, and the role that family and other unpaid, informal, whatever, carers play. Those roles are really important to understand what the future will be for dementia care. And then my final very quick comment would be going from disease or burden to costs is a great step. What many policymakers now say is, okay, costs a lot of money, that doesn't help us to decide what to do, so we need to go the next step, which is, what do you do, and what's the economic and other arguments for doing those new things, whether it's prevention or care. So that's the next step. Thank you.
Well, that was an important intervention. I think I'm going to call Maëlenn next. And something that we, again, we need to think about is what is happening also in African countries that Martin referred to. Maëlenn is currently based there, and she was, of course, the author of our African report. Maëlenn, can you hear us? I can see that you're frozen on the video.
I can hear you now, but pretty unstable here, sorry.
That's good. We can hear you and see you. If you would like to give us your comment to what has been discussed so far, that would be great. There may be a delay. So whilst we wait for Maëlenn to come back. Maëlenn, are you online? No.
I am, but I can't hear you well.
Okay, then we will move to the contribution of Nick Farina, who is doing some really interesting and relevant studies. What is your view on what's been said so far?
So, yes, so I'm working also within the STRIDE project, and I suppose reflecting on some of what the things have been said so far on the panel, I'm thinking about the practicalities of actually collecting this high quality data, this high quality localized data that Sube highlighted was so important. And I think something we need to be vigilant about is that when we do look at we think about countries and we think, oh, we want to collect this data, we need to remember that countries aren't homogeneous groups of people, that different regions will have different languages, different ethnic groups, different cultural groups. And I think it's really important for us to plan in, when we're thinking about collecting this novel data, about how we can ensure that our questionnaires, our tools that we're using, are culturally appropriate and linguistically appropriate for each of the countries and the regions that we're working within. And I think within STRIDE that's something that we try to prioritize. We tried to ensure that we did this forward and back translation, and we did implement kind of the cognitive interviews to find out whether the measures were actually measuring what they're supposed to be doing. But also we wanted to ensure that when we were looking at individual settings that, yes, we were collecting information on prevalence, yes, we were collecting information on cost of care, but also we wanted to ensure that the measures that we included were going to be most useful for local stakeholders. So that's why, for example, within South Africa, we've got this outcome of elder abuse, because it was seen as such a high priority within our team, within other stakeholders. So I think we need to be vigilant about ensuring that our tools are going to be fit for purpose and going to meet the needs of local stakeholders.
Thank you so much. And actually, you've just raised something that reminds me, for those of you who haven't seen it, the 4th National Plan for Dementia of South Korea, certainly not a low-income country, a high-income country, reports for the first time their figures on elder abuse, which was a bit of a shocking thing to read, I have to say. So I do invite you to go on our website and read that. It's the first country in high income that has the courage even, I think, to report formally on that. Shocking statistic. Now, we've heard from many people. I'd like to circle back a second to Theo. Theo, you're on the line with us. Would you like to comment on what you've heard so far?
Yeah, thank you very much. I think your technical people know how to take away an echo, I noticed with other speakers. Yeah, that's good. A few comments. Maybe just first to the question about linking epidemiological data to cost estimates. We actually have quite a stream of work at IHME on the costs of dementia, and we're benefiting a lot from having regular contacts with Anders, between the people at my institute and who are doing this kind of work. So we recognize this is an important part of the information that is needed. On the estimates of dementia, they are particularly challenging because of the large heterogeneity at which the information is being collected, as Emma pointed out. And having experience working on multiple diseases, dementia ranks pretty highly as a difficult disease because of the heterogeneity in the input data. Now, for that reason, for us, it is important that we are currently working on expanding the number of risk factors that impinge on dementia. Because if we have a better handle on the impact of those risk factors on incidence and prevalence, then it can statistically make our models a lot more stable, where we can infer strength from the relationship between risk factors and an outcome like dementia, and not just have to deal with the data as they are being presented. Thank you.
Theo, thank you so much. Actually, because you mentioned one thing in particular, I meant to call on Adelina, who will have instead the last intervention, but I'll call instead now on Rodrigo. There was a mention of heterogeneity, and Rodrigo, you are trying to address some of these issues in the dementia research blueprint. Can you tell us what you are doing at WHO around those areas?
Absolutely. Thanks, Paola. Yes, definitely a big issue that has been raised here today is the lack of quality of data, and then that pertains to geographic representation, ethnic, socioeconomic backgrounds, and the lack of quality data impacts our estimates and estimates that IHME and all the colleagues that are working on. So there's this lack of diversity that impacts also demographic data that are essential to come up with this estimate, incidence of risk factors. All of this lack of quality data impacts the generation of these estimates. So what we're trying to do with the dementia research blueprint, which little advertisement, you can watch a session, online session on this also in the conference. We are trying to come up with a roadmap on how to address the major issues in different themes of research, and one of this is epidemiology and cost data, where we have specifically the research gaps, the actions that need to be done to address these gaps, also milestones to achieve some strategic goals that we are laying out there. And many of the experts in the world, some of them are here with us in this panel, are supporting us. And please watch the session, because it's our way forward on research for this data. Thank you.
Rodrigo, today in Côte d'Ivoire, I believe, and it's important to mention the Dementia Research Blueprint, because of course it's one of the many initiatives that are being done to try and make us all access data in an easier manner. Now, I understand that Maëlenn is actually listening to us, and again, a disembodied voice, but Maëlenn, can you intervene? Can you give us your view on this?
I'm here. Is that better?
Excellent. The ghost of Maëlenn, yes, we can hear you.
Thank you. I obviously agree with plenty of things that have been discussed today by many of the speakers. And I think one thing that has been a strength in the past, definitely 66, and probably for STRIDE as well, and for many other research initiatives, are actually the constitution of consortiums and working together in different countries which may have similar issues or are closed in many ways with their health systems, with their research organization, and I think that's a strength that might be something which could support, as Martin was saying, the transition for governments as well to collect data. I'm happy to report that there's actually such a consortium trying to emerge in dementia in Africa, with plenty of countries involved. And if there's no funding yet, or maybe not much, I just hope that making efforts towards the same goals, which is obviously a better description regarding epidemiology, but also going towards policy. I hope this is going to help and provide more data on care, costs, and obviously numbers.
Thank you very much, Maëlenn, who has also mentioned funding. For those of you interested in that topic, the excellent roundtable that has been run by Daisy Acosta is a virtual roundtable that was pre-recorded, addresses that point at quite some length. It's a roundtable on 1066 and where it is right now. So I will advise you to view that. Now we have a very few minutes, but I would like to give the floor to Adelina, who has patiently listened to all of that and is a passionate person on this topic. So a few thoughts, Adelina, from you, but also I'd like to have at least one question from the audience. So if you can start thinking about what the question may be when you have all the world experts in the world on this particular topic, it would be lovely to hear what you have to say.
I can say whatever I like now.
You can.
I'm going to start from a different place, and I'm going to go back to the session we had on how many plans, how many national dementia plans we have. And I'd like to emphasize that not all dementia plans are equal. And the ones that I think we like the most are the ones where there is a budget attached to them. And when there is some funding attached to some actions that are going to improve the lives of people with dementia and the experience of the carers who are supporting them. And how do we know what to ask for in a national dementia plan when you are an advocate and you want to improve things and you need to say, oh, we need some money? You really, to be able to be successful, you have to show that you're going to spend it on something that will actually make a difference, that is going to be a good use of money. As Martin was saying, we want to make sure we're looking for cost-effective interventions, and we need to know how many people this will reach and how much difference will that make. Now, for that, we do need all this data, because we need to know Not only how many people have dementia now, but what type of care are they getting? What's their current situation? How many are not getting what they should be getting? And when we project costs to the future, let's remember that what we're projecting to the future is not good. It's not good enough. That's why we're all here, because we want to improve things. And we need to have these really detailed, fine-grained data on individual experiences. And with it, we need to also have evidence on what works. We also need to have evidence on what is it that people think might work in their context, given their systems, given what the good things they already have in their countries that they can build on. Is it training faith healers? Is it maybe going to be a special, again, training of community health workers in recognizing the early signs? Now, we can cost all that. We can work out how much we need to be able to have each of those things in a plan and really advocate for it then. And without this data, we'll end up with lots of empty, lovely, really nice aspirations in national dementia plans, but perhaps we won't be able to have as much success in practice if we can't argue really forcefully for more funding in a way that is credible. And that's my point. Thank you.
Thank you very much. So true. We do need, and Anders, of course, has provided us over the years with a lot of facts and figures that we've used in advocacy. Even that, though, one has to say, even with the best facts and figures, the government still don't listen, but we will not give up. Now, we have a few minutes, literally very few minutes. I would like to see hands up, if there are any, or are you all too intimidated to ask questions? If you are, Ishtar is not intimidated, I knew that. Ishtar, it's your turn, and of course, in the second there. So if we could, yes, we got a volunteer with a microphone. Ishtar first. Thank you.
I was wondering if the methodological differences that you were talking about in the diagnostic inputs, do they cluster in any way? So do they cluster in terms of the tools that are used in, for low and middle income countries, or do they cluster to different regions of the world so that you're seeing this heterogeneity manifesting in a specific way?
Can I ask on the panel, we have to be quick here, Martin first, Emma second. Emma first, Martin second. Emma?
That's a great, yes, can you hear me?
Yeah.
So that's a great question. I think we've done our best to sort of try to group a lot of the different ways that people measure dementia into sort of broader categories to try to use those in statistical models to adjust estimates. So grouping together things like any diagnostic algorithm-based assessment of prevalence versus diagnosis given by a physician or adjudication panel. I will say, I think there is some amount of clustering that you can sort of observe by just level of funding. A lot of places need to rely on algorithms where there aren't enough resources available to support more thorough adjudication panels or complex procedures. And so you definitely see that, but it's still sort of this, even when creating these groupings, there is still a lot of variability within those groups. And so coming up with sort of a set of best practices for measurement across a variety of different settings, I think is one direction that we could go to sort of help reduce the amount of variability even within these different categorizations.
Thank you, Emma. Martin, if you can hear us, do you have any views on that, please? Yes, you can hear.
Is that me, Martin?
Yeah, great. Yeah, Martin, sorry, yeah.
Okay. Right, sorry, two Martins.
So you're right.
Yes, so I have some thoughts on this, and it's something that we looked at, you know, with the earlier world estimates, where we did try to drill down to what might be underlying what is undoubtedly the kind of large heterogeneity in general that exists amongst estimates. I think one of the clearest things is that the 1066 Dementia Research Group diagnosis, you know, delivers a higher prevalence than DSM-4 or ICD-10. And the reason why we're particularly confident about that was because we applied both sets of criteria to the same data, and because we were rigorous to include, all of the necessary information essentially to enable us to apply the DSM-4 and the ICD-10 diagnoses by algorithm rather than by a consensus panel. So that seems to be one generic issue, but you do get this extraordinary kind of variation even within DSM-4 and within ICD-10. And I think a lot of that is about the information that goes into the application of the diagnostic algorithm. Amongst the things that we looked at, I think a critically important one is, has there actually been an informant interview? So when we make a clinical diagnosis, we speak with the patient, we do some cognitive tests involving multiple domains, but you will miss the diagnosis or get it wrong if you do not speak with a caregiver or a family member that knows the older person well. But lots of studies actually do not include a structured informant interview. You'd think that that might be important. When we looked at that, particularly with European data, where there were the largest numbers of studies, that didn't actually seem to be a determinant of the variation in the prevalence. The other one was whether a multi-domain cognitive test battery was used or not. And again, many studies don't use cognitive test batteries, but that didn't seem to be a driver of variation of prevalence. So I think what I would argue for is looking at those sort of functionally important kind of elements of the diagnostic assessment that actually go into whatever algorithm is actually in the end being applied. And what I would say is that the 1066 Dementia Research Group diagnosis, the difference between that and DSM-4 was greatest in the least developed settings where awareness of dementia was lowest, where the discrepancy was really with DSM-4 and ICD-10, which were unusually very, very low indeed. And I suspect that our method, if applied in high-income countries where awareness in the population was relatively high, educational levels were higher, that probably the discrepancy would be smaller. So it is complex, and we certainly didn't find any clear answer to that question up to 2015, which was the last occasion when we'd looked at it.
Thank you very much, Martin. Now we got another question. I've got 2 minutes. I'm not going to waste them. It's here, just here in front. And the reply will have to be very quick. Your question.
So my question is, it's really great what everybody is doing around like the cost side, but it seems we are getting more research data that's talking about from a care side, like if we do certain forms of care, we have cost savings. And also, even from a prevention point of view, if we do certain activities, well, that will reduce, let's say, incidence. So and often, is there a case like for a business case? So we have both the cost data, so this is what's going to happen. This is what these are some savings that can be made. Now, in terms of dementia, would that help as we get like the money we need, both in terms of, getting better cost data, but also providing better care and assisting with prevention? And just
find the right panelist for you. I need to ask you, where are you coming from?
So sorry, I'm coming from Sydney, Australia.
But from a non-governmental organization, from a university?
Okay, so I've just submitted my PhD thesis in dementia care. I was formerly a carer for my husband with younger onset dementia, and prior to that I worked in the corporate world.
Okay.
Large IT program.
Very interesting. Thank you so much. I'll ask Martin and Anders to give me a super quick reply.
Super quick reply.
Martin Knapp this time. Yeah. Sorry.
So firstly, we've just been asked exactly that question by government here, and come back in 2 months. We'll tell you whether there's evidence, which will then allow us to do a sort of return on investment approach. But there are 2 studies which have come out in the last couple of years, which would be, or one is about to come out, be really helpful. One is that with Jill Livingston's group, paper led by Nahid Muqaddam, we looked at 4 midlife risk factors for dementia, diabetes, smoking, hearing loss and hypertension, looked to see what interventions worked in midlife, and then looked to see what the cost savings would be linked to dementia. Secondly, FINGER program, which we know a lot about, and has led the economic evaluation of that.
Yeah, we have a paper in press now about the cost effectiveness of the finger intervention, and to make it very short, that the benefits on case level are rather modest in a way, because we do have some slight cost savings, we do have some positive effect in terms of outcomes, but since the target population for this prevention is so big, so the socioeconomic impact from a society viewpoint might nevertheless be very big, because so many people may be target for this kind of prevention activities.
Very much. That was brief indeed. And can I remind you that we have both Jill Livingstone and Mia Kivipalto tomorrow for risk reduction. Now, I need to thank my panelists. I will not name them because there were so many of them, and they weren't panelists. We were doing a round table with access. So I hope you've enjoyed this discussion. These discussions will continue. And judging from the amount of people that are interested in them, we may have to open them up more often. The other thing I would like to say, the people that are in this roundtable give us, all of us that work in advocacy, the tools, the weapons that we need to do what we do. Without what these guys do, we would be naked in front of the wolves that can just say, go back to your drawing board, you haven't got anything to persuade me. So we really owe to the people that have been interacting in this roundtable a massive debt of gratitude for embarking in this complex area of study, and responding is like a ping-pong game. Whenever people say it's not true, they have got the answer. And that answer has enabled us to really change the life of people living with dementia and their families for the better. A big round of applause to them. Thank you. Grazie, onward and forward to the next one.
Is mankind, O brave new world that has such people in it.
Stop sitting around in your comfy chair. Gaze out of your window, look